time for your body and you. And this morning we're going to be talking about endometriosis. What are its causes, the symptoms, treatment? And to do so with us this morning is Dr. Gordon Arinsing, obstetrician and gynecologist. Good morning to you, Dr. Arinsing.
Good morning, Natalie, and good morning to the rest of the panel.
And I know you really took time out of your schedule to be here, so we really appreciate having you with us this morning.
Yep, ma'am. And it's a pleasure to be here. It's a pleasure to participate in this very important condition to a lot of ladies in our country.
So, Doc, we had a conversation 2 weeks ago about fibroids, and coming out of that, you know, somebody asked me to speak about endometriosis. So let's just start with a basic definition of what endometriosis is or what it means.
Right. So the endometrium is the tissue that is in the uterine cavity. And, what happens, however, unfortunately, it is found outside of the endometrial cavity, around the tubes, the ovaries, predominantly the back of the uterus. And this will cause symptoms and pain.
Okay, so explain that to us again.
Am I getting the link up here? I'm not too sure. I think I've put that. Yeah, I'm not too sure if I'm getting through.
Yes, the connection is really kind of sticky. It's a sticky situation, Doc.
Yeah, are you hearing me? I'm trying to see if I get right. So that is what happens. The tissues that are formed within the uterine cavity that normally a woman will, at menstruation, will leave her body. Unfortunately, those tissues are outwith of the endometrial cavity and within the pelvis. And when the patient has a period, this material remains in her body and it causes a fair amount of disease and disability.
Dr. Arinsing,
scarring and pain.
Dr. Arinsing, I'm going to ask you to change position. So I'm going to take a short break and give you a little time to do so. Don't hang up. Just see if you can change positions, because one of the things I really don't want to happen is that, you know, we end up losing this information because of connectivity issues. So if you could just change your position, I would appreciate that. So we're trying to speak with Dr. Gordon Arinsing, who is an obstetrician. I can't say that word, at least not with any speed. And gynecologist, who's here to speak with us about endometriosis, and he's talking about the endometrium. And, you know, I hear tissue and I hear uterus, I hear lining, and I hear outside of that interpelvic area. So we'll try to make sense of all of it when he's back with us. Doc, do you have a better position as yet?
I'm going to try and see if I can locate something. Where is he?
Right. So while Doc organizes that, what I remember is that when we spoke about fibroids, when we spoke about fibroids 2 weeks ago, is that, you know, we learned so much about how, you know, just how it affects the woman's body, but apart from the body, how it affects mental health. How when you have these other, what people perceive as vaginal issues or issues to deal with the reproductive organ, how it affects mental health. And even when we spoke last week about, what's the one we spoke about last week? Hot flashes, the one that brings hot flashes?
Menopause.
Menopause.
Yeah.
All right. Dr. Arinsing?
Yeah.
Yes.
You hearing anything better now?
Let's get wade into it and see.
Okay. So what I was saying is about endometriosis is when the tissues within the uterine cavity, which a woman normally is called the menstrual fluid tissues, every month that is shed and, you know, leaves her body. Unfortunately, women with endometriosis, these parts of the tissue that were supposed to be within the uterine cavity is found outwith of that, around the tubes, the ovaries, and the pelvis, the other parts of the abdomen. And when this person has her periods, these tissues break down inside of her and causes intense pain and scarring, and that leads to disease
Wow. So this is sounding very serious. Do we have different kind of reactions based on where these tissues find themselves?
Well, the thing about it is that inflammation and scarring is very patient dependent. There's some women, I mean, a substantial amount of women will have endometriosis, maybe about 20% of the population, but maybe about 5% of, or maybe a quarter of that group will have what you call endometriosis that causes disability, pain, disease, affects their fertility, affects their whole quality of life. So it means that there is a relationship with the amount of endometriosis one has, but some women tend to react more severely to this endometriotic tissue, which exists out of the uterine cavity. And that group of women are much liable to develop symptoms as what we were trying to address right now. So
Right.
it's an inflammation, it's a scarring that really causes a substantial amount of the disability and disease.
Right. Doc, and I was asking if when we end up with that tissue outside of the uterine cavity, if we, depending on where it falls, if we'll have different reactions or different levels of scarring.
Well, yes, because if it can develop around your ovaries, it can develop in just behind the uterus in that area close to the large bowel, the sigmoid colon, the rectum. It can develop around the bladder. So it is to a certain extent site dependent. So that some patients develop bladder problems, some develop bilateral ovarian pain, which radiates down their legs and the inner aspects of their thigh. Some patients develop severe rectal pain, especially around their periods. They develop tenesmus, and sometimes they have even rectal bleeding at the time of the periods. So it's quite a severe, debilitating, infiltrative type disease that can cause significant harm to a patient in terms of quality of life and ability to function in society. She will become equipped with this pain and this disease.
Right. And talk to us about how it affects fertility, because you're talking about forming outside of you said the ovary. Go ahead, Doc.
It affects fertility. It can affect fertility by causing a fair amount of scarring. And this scarring can damage the tubes as well as affect tubal function and ovarian function. But apart from that, it appears that endometriotic implants also affect the fluid that is released at the time of menstruation. It's quite toxic to the sperm as well. That fluid also has a negative effect on the so you'll find that some patients have very mild endometriosis, but they can't get pregnant. And it's because that fluid that is released by these endometriotic implants are what you call toxic to the sperm, the egg, and as I said, the embryo. And that can affect fertility as well as the scarring. But those are the two areas that are well established with respect to fertility. And a substantial amount of women with endometriosis have problems in conceiving. More than 50% are infertile or relatively subfertile.
Right. And I remember you said, I heard somewhere in the discussion since we started, is that a lot of us as women suffer from endometriosis but don't know because it's some kind of mild version. But then there are the 5% who have really debilitating effects of.
Exactly.
And
we can pick it up incidentally. Sometimes you're doing surgery and you see implants of endometriosis, even at a cesarean section, even while doing tubal sterilization and laparoscopic sterilization, you see implants. These patients are perfectly fine. And that creates a little bit of the enigma. What really is, how does endometriosis cause this serious condition? And the thing about it, Natalie, is that you have to have this high index of suspicion when young people present or anybody presents with severe pelvic pain, severe period pain, painful intercourse, pain on bowel movements, sometimes severe abdominal pain with vomiting around their period time, a crippling pain that affects their quality of life, their ability to work. They're taking every month, they're taking more and more painkillers to try to get by, and they still have becoming refractory to this amount of pain relief. And these women, form the subset that you have to consider endometriosis in your differential diagnosis. The unfortunate thing, Natalie, if I could expand a little bit, is one of the major problems of endometriosis is the delay in diagnosis. And that allows women the condition to perpetuate and become even worse. And by the time they present to us, they have such bad disease, it's very difficult to treat them. It's quite challenging. And that is what I would like to emphasize to the entire population, women population, that if you have any of these symptoms, go and see one of my colleagues or myself, or whoever, gynecologist particularly, who is tuned into this sort of condition, and can start investigating and treating it.
But Doc, what is it that we're missing? If you're talking about diagnosis, is that if we have all of this pain, as you said, it could be pain close to the rectum, it could be pelvic pain, abdominal pain, pain with period. What is it that what is it that the doctors are supposed to do? Because really, if we have this pain, we can check in with our GP. Should we just automatically check in with our gynecologist? Walk us through the process so that, you know, even us as patients or even doctors, we know what to check for.
But I think a general practice most of the population has a general practitioner who they relate to. And the GPs, having been in a senior lecturer for a while at UWI, and we've taught the importance of endometriosis and to recognize it in medical schools. So our GPs are very familiar with this condition, and that's great. They should now, maybe they can offer an ultrasound to make sure that the patient doesn't have any other large endometriotic implants or any other conditions that are causing this condition. And if they do a pelvic examination, they sometimes can detect nodularity within the pelvic area around the vagina and the fornices. And they can then refer this patient to the gynecologist. And the earlier they refer the patient, the easier are we to establish a diagnosis or have a high index of suspicion. And then we can be able to embark on treatment and to control the condition.
Okay, so an ultrasound of the pelvic area can say what the issue is.
Not really. An ultrasound is a good investigation. It's not going to give you all the answers. The way that we investigate definitively endometriosis by doing a laparoscopy. By looking to the pelvic area, by more than likely the gynecologist will do that. The thing about it, not everybody can lend themselves to laparoscopy and be available and can afford a laparoscopy or can get it in the public sector. And therefore, that limits the amount of investigations, the gold standards of investigations that we could offer to patients with suspected endometriosis. Mm-hmm. But you can have a high index of suspicion. And if you do feel that this patient is a patient who will require treatment with endometriosis, then we can start certain medical treatments to offer what you call the soft options, which will be able to control her pain and her quality of life and improve her quality of life.
Right. Talk to us about the treatment options, Doc, because I'm sure that they'll be different depending on, you know, where this tissue is falling and, you know, the symptoms that you're having.
Right. That is very, very important. And the treatment options are divided into either where patients have medical treatment, what we call hormonal treatment. Essentially, what you want to do is the endometriosis depends on estrogen. And the more estrogen is produced in the body, the more likely the endometriosis will grow and develop. So if you can negate the endometrium by physiological, pharmacological medications that negate it, like progestogens, or certain medications that temporarily shut the ovaries down so you don't produce any estrogens during that period of time, maybe 6 months, then that will be able to allow the body, the endometriosis, to stop growing and developing, and allow the body to be able to use its own immune system to counteract what existing disease is there. And that is quite a useful strategy. Sometimes you put patients on the continuous combined pill for maybe 3 cycles that will control the amount of periods. So instead of having a period every month, they will have one every 3 months or so. And that there is some benefit for that in controlling them. The key thing about treatment, Natalie, is what the patient wants. Is a young girl not desirous of having a baby at the point, you can control her disease and symptom control by giving her hormonal treatment, preferably the pill, maybe some progestogens, and you can allow her to continue and carry on and follow along the course of her reproductive life. If eventually she changed her what she would her mind and she wants now to start a family, then you have to adjust that because you have to offer alternative strategies. Now we have another group of women who have infertility and endometriosis, and that is a particularly challenging group because those people have disease, but they also want to have a baby. And they are in their 30s, and the window of opportunity that they have to have a baby is closing. And in that group, you will have to be a little more, I wouldn't want to use the word aggressive, but much more attentive to their needs. And I would consider that in that group of patients, you might have to do surgical treatment to resect the endometriotic implants because you want to reduce the endometriotic burden quickly with surgery. And then you can put them on some medical treatment and then stop all treatment so they can now go ahead and try to have a baby. So there are different strategies depending on the needs of the patient and the age of the patient and their circumstances. Right. In the older woman who has endometriosis, who completed her reproduction and has had all of its babies and everything, then you might want to do completion surgery. And these patients may have to have a hysterectomy of tubes, ovaries, and they become disease-free and they could continue to carry on in life. So it's fairly individualized, and you have to know your patient's needs before you can address, and you have to titrate it basically to what is the patient's needs. And that is a very, very important as a clinician that you have to do.
Right. All right, Doc. Well, I'm just hoping that going forward that more doctors are able to diagnose, people with endometriosis. As you said, it's one of the areas that needs improvement where diagnosis is concerned. And as you said, start with that ultrasound, but you may have to move to that laparoscopic
procedure.
Yeah.
I want to, before we close off here, I want to tell you the delay of diagnosis is not unique to any part of this world. Looking at the literature, from the time a patient presents with the symptoms to establishing a diagnosis in Europe, it's about 10 years. In Britain, it's about 8 years. The average delay in diagnosis is about 7.5 to 10 years all over the world. And that is why we have to create what we call more patient as well as doctor awareness to this condition. Delay in diagnosis is proving to be our biggest challenge right now in the management of endometriosis. Yeah. And therefore, we should tune in a little better, not tune in also to your station, but to tune in mentally to the presence of endometriosis if you have a patient with pelvic pain. There are many causes of pelvic pain, like infections, like fibroids, like ovarian cysts, but endometriosis has to be on the cards to consider, and that's very important.
All right, Dr. Narayan, thank you so much for sharing your wealth of knowledge with us this morning.
Thank you very much, Natalie. I'm sorry about a little technical hiccup, but I hope that the audience will have got the message.
Yes.
Thanks for inviting.
You're most welcome. Bye. Dr. Gordon Aransing there talking to us. 7.5 to 10 years delay in just getting that diagnosed. So pay attention. We're going to take a break and we'll be back with you.